Welcome to the Deep Dive. Today we're tackling a really interesting section from Rutherford's Section 24, Miscellaneous Venous Conditions. We're aiming to sort of create a practical guide from chapters 162 to 166 for vascular surgeons facing these sometimes quite tricky situations.
Exactly. Think of it as the key takeaways, the actionable stuff distilled from expert knowledge on SVC occlusion, portal hypertension complications, Nutcracker syndrome, and, a few others. We want to cut through the noise and focus on what you really need to know in practice.
Great, let's start with chapter 162, Superior Vena Cava Occlusion, SVC syndrome. Can you give us the core problem here? Quick overview.
Sure. So fundamentally, SVC syndrome is about venous congestion. Your head, neck, upper extremities get congested because blood can't drain properly through the superior vena cava or maybe the innominate veins.
And how common is this?
It's estimated around 15,000 cases a year in the U.S., and interestingly, the reasons why it happens have been shifting a bit.
Shifting. How so?
Well, malignancy, things like lung cancer, lymphoma, that used to be and still is a big chunk, maybe 60%.
Right.
But the benign causes, they're up to about 40% now.
Okay, 40% benign. What's driving that increase?
It's largely down to indwelling devices, central venous catheters, pacemakers.
Right.
We implant millions of catheters and hundreds of thousands of pacemakers annually.
Right.
And these devices carry a risk of DVT and subsequently SVC syndrome. It's maybe 1–3% for catheters, a bit less for pacemakers, but the sheer volume makes it the leading benign cause now, something surgeons really need to be aware of.
Definitely. So if you suspect SVC syndrome, what are the classic signs? What should trigger that thought?
Patients often complain about a feeling of fullness in the head or neck, maybe visible swelling, shortness of breath, especially when lying down, orthopnea, that's common too.
And prominent veins on the chest.
Yeah, exactly. Large chest wall collaterals are a big clue. Headaches, maybe some facial cyanosis, dizziness, arm swelling. It's quite a range. And on exam, you might notice the normal respiratory variation and flow in the subclavian veins is just gone.
Okay, so you suspect it. What's the next step for imaging? What's the workhorse?
CTA, computed tomographic angiography, is really the first-line test nowadays. It's fast, widely available, and it shows you the location, the extent of the blockage.
And it can help figure out the cause, too. Benign versus malignant?
Often, yes. You can see if there's a mass compressing the vein or if there's a catheter or pacemaker wire involved. Plus, it maps out all those collateral pathways, the azygos system, internal mammary, lateral thoracic veins, how the body's trying to bypass the blockage.
What about other options like MRV or traditional venography?
MRV is good, especially if you want to avoid iodinated contrast. It gives great anatomical detail in different planes, but, it's not for everyone. Patients with pacemakers, for instance, or those who can't lie flat. And gadolinium concerns have limited it somewhat, though newer agents help.
And contrast venography, the old gold standard.
Yeah, historically, it was key for anatomy and flow patterns. Now, it's mostly used during endovascular treatment to guide the procedure. Still useful to know the Stanford and Doty classification, though the 4 types based on obstruction site and collaterals helps conceptualize the problem.
Right. Let's talk treatment. How does the approach differ based on whether it's malignant or benign?
Big difference. For malignant SVC syndrome, you're primarily treating the cancer radiation, chemo, but stenting the SVC has become incredibly important.
As an adjunct.
Exactly. It provides really rapid symptom relief, like 95% success reported, often done before radiation if the stenosis is bad, because radiation can initially cause swelling and make things worse. So stenting can really improve quality of life during cancer treatment.
Makes sense. And for the benign cases, the catheter-related ones, for instance.
There, endovenous treatment is now often the first choice. Angioplasty, stenting, maybe thrombolysis if there's clot. Techniques have improved so much.
So surgery is less common now.
It's generally reserved for the complex cases, maybe really chronic fibrotic blockages where endo isn't suitable, or if endo fails. Or specific things like mediastinal fibrosis, sometimes complex pacemaker wire issues.
Let's dig into that endovenous toolbox. What are the key tools and techniques?
Well, it started back in '86, actually, with an angioplasty for a pacemaker wire issue. Now we have balloon angioplasty, of course, but also various stents. You've got self-expanding ones like wall stents or Zilver-Vena for longer, twisty lesions, and balloon expandable ones like POMAs for precise placement.
And covered stents.
Covered stents like Viabon are useful too, especially in malignancy to stop tumor growing through the stent. They might offer better patency, though we're still gathering long-term data. And then there's thrombolysis using TPA, usually catheter-directed, to dissolve fresh clot before you angioplasty or stent.
Okay, walk us through a typical endo procedure. Access,
Yeah.
challenges.
Access can be femoral, jugular, subclavian, depends on the anatomy. You use long sheaths, maybe specialized wires to cross the blockage. Then balloon angioplasty, usually 10-16 millimeter balloons. Then stent placement tailored to the lesion. Sometimes multiple stents are needed.
Overlapping?
Yeah, overlapping stents are common. And you often need to post-dilate self-expanding or covered stents to get them fully open. If the brachiocephalic confluence is involved, you might need parallel or double-barrel stents.
Any major risks? Perforation?
Perforation can happen, usually managed with prolonged balloon inflation, maybe a covered stent. Very rarely you could get SVC rupture and tamponade, which is obviously an emergency needing pericardiocentesis. And anticoagulation is key heparin during, then usually oral anticoagulation or antiplatelets for at least 6 months after, maybe longer, depending on the cause.
Okay. Now, what if endo fails or isn't an option? Let's talk surgical reconstruction. What grafts do you use?
Autogenous grafts are tricky because you need something big enough. Saphenous vein is usually too small for direct reconstruction, though you can sometimes use it for an extra anatomic bypass, like jugular to femoral.
What about femoral vein?
Femoral vein is a better size match, and it works well. The main concern is DVT or swelling in the donor leg, especially if the patient has a clotting disorder. But for SVC, the side effects seem less problematic than in arterial bypass. For young patients with benign disease, though, the spiral saphenous vein graft, the SSVG, is often preferred.
Spiral saphenous. How does that work?
You harvest the saphenous, open it up, take out the valves, then wrap it spirally around a chest tube, like a 32 or 36 French, and suture the edges. It lets you create a custom diameter autologous conduit. Pretty neat technique.
It sounds it. And prosthetic options.
Primarily externally supported EPTFE. Short, large diameter ones, say for an innominate anastomosis where flow is high, they do really well long term. If you're anastomosing more distally, like to the subclavian, flow is lower and patency isn't as good. Sometimes you need an AV fistula to boost inflow.
Is EPTFE better sometimes?
It can be, especially with malignancy. Its stiffness resists tumor compression. Post-op anticoagulation depends on the graft, maybe shorter for autologous if no clotting issues, but often lifelong for EPTFE or if there's an underlying disorder.
How did the results stack up, endo versus surgery for SVC syndrome?
For malignancy, endo, especially stenting, gives rapid relief and good palliation. It's really become first line. For benign disease, endo has good midterm patency, maybe 70% primary at 1 year, but needs more reinterventions than surgery long term. Assisted patency is actually quite high, comparable to surgery initially.
Can surgery?
Surgery, when needed, gives excellent long-term results, particularly the SSVG DOTI reported 88% patency at almost 11 years mean follow-up. Our own experience is similar. Femoral vein grafts also have good patency. EPTFE works well in the mediastinum, especially shorter grafts. Overall, surgery is a durable solution for endo failures or unsuitable cases.
And surveillance after treatment, is that important?
Yes, definitely. Duplex is okay for indirect assessment, but CT or MR venography is recommended baseline before discharge, then maybe 3-6 months, and a year post-op. Most stenoses tend to show up in the first year or two.
Okay, let's shift gears to Chapter 164. Complications of portal hypertension. What's the basic problem that leads to things like variceal bleeding?
It's all about high pressure in the portal vein system, portal hypertension, or PHT. When that pressure gets about 10-12 mmHg higher than systemic pressure, the body forms collateral vessels to try and bypass the liver and decompress the system.
But these collaterals aren't perfect, right?
No, the pressure stays high. And that high pressure in thin-walled varices, especially esophageal or gastric ones, leads to dilation and thinning. Eventually, wall tension gets too high, and they rupture. That's the explosion hypothesis, basically Laplace's law in action.
Is there a pressure threshold for bleeding risk?
Yeah, the key measure is the hepatic venous pressure gradient, the HVPG. Once that hits 12 mmHg or more in someone with varices, the bleeding risk goes way up. So a lot of treatments aim to get the HVPG below 12.
How do we diagnose PHT and check for complications?
It's a mix. Lab tests, liver function tests like AST, ALT, bilirubin, INR help gauge liver dysfunction. Specific tests can pinpoint the cause, viral hepatitis, autoimmune, etc. But endoscopy, upper GI endoscopy, is absolutely critical.
To actually see the varices.
Exactly. You need to directly visualize esophageal and gastric varices, grade them, see if they look high risk. It's essential for diagnosis and follow-up, especially after a bleed. Liver biopsy can also be useful to determine the cause and severity of the underlying liver disease.
All right, managing PHT. What are the main non-surgical approaches, especially for variceal bleeding?
The goals are prevention and control. For primary prevention, stopping the first bleed, non-selective beta blockers like propranolol or carvedilol are key. They lower portal pressure.
For everyone with varices.
For medium or large esophageal varices, or even small ones if they look high risk, endoscopic band ligation, EVBL, is another good option for medium-large ones. For gastric varices, sclerotherapy might be used.
And if someone is actively bleeding?
That's an emergency. You use vasoactive drugs, vasopressin, terlipressin, octreotide to reduce splanchnic blood flow and portal pressure. Endoscopy with banding or sclerotherapy is crucial. If that fails, balloon tamponade with a Singstake and Blakemore tube can be a temporary bridge.
What about more advanced non-surgical options? BRTO, TIP-BS.
Right. BRTO balloon occluded retrograde transvenous obliteration is mainly for bleeding gastric varices, especially those fed by large gastrorenal shunts. You block the shunt and inject sclerosant. TIP-PS transjugular intrahepatic portosystemic shunt creates a channel within the liver between the portal and hepatic veins.
To bypass the liver resistance.
Precisely. It decompresses the portal system. Early tips after a high-risk bleed improves outcomes. It's also used for refractory ascites or gastric variceal bleeding.
How are other complications like ascites and encephalopathy managed?
Ascites usually starts with salt restriction and diuretics, spironolactone, and furosemide. If that's not enough, large volume paracentesis or TIPS might be needed. For encephalopathy, you treat any triggers like infection or bleeding and use lactulose to help clear ammonia. Sometimes antibiotics like neomycin or rifaximin are used.
What if there's thrombosis involved? Portal or hepatic vein thrombosis?
Sometimes recanalizing those thrombosed veins with angioplasty and stenting can actually reduce portal pressure and symptoms. It's an option, especially in Budd-Chiari, maybe before considering TIPS.
And surgical shunts, are they still done?
They are, but less often now, usually after non-surgical options fail. You have portacaval shunts, mesocaval shunts, and the selective distal splenorenal shunt or Warren shunt. They effectively prevent rebleeding, but tend to cause more encephalopathy than TIPS or endoscopic therapy.
How do they compare to TIPS?
Studies comparing selective shunts to TIPS show similar rebleeding and survival, but TIPS often needs more reinterventions due to stenosis or thrombosis. Of course, liver transplant is the ultimate solution for many with end-stage liver disease and refractory complications.
Okay, let's tackle our last one. Nutcracker syndrome, chapter 165. What exactly is being compressed here?
It's the left renal vein. Usually it gets squeezed between the aorta and the superior mesenteric artery, that's anterior nutcracker. Less commonly, a retroaortic left renal vein gets compressed between the aorta and the spine posterior nutcracker.
But isn't some compression normal? The Nutcracker phenomenon?
Exactly. You can see anatomical compression on imaging in people with no symptoms at all. That's the phenomenon. Whether it constitutes a true clinical syndrome is debated, especially since ligating the left renal vein during, say, aortic surgery is often tolerated fine.
Interesting. So who gets the syndrome? Is it common?
We don't really know. The prevalence. Lack of clear criteria makes it hard to study. It's often described in young, thin women, but it can affect men and older people too. Low BMI seems to be a factor. Interestingly, asymptomatic compression is seen in maybe 10% of abdominal CTs.
What's the specific anatomy that causes the squeeze?
In anterior NCS, it's often a very acute angle between the aorta and the SMA, maybe less than 35 or 40 degrees. Less fat padding in the retroperitoneum can contribute. This compresses the vein, raising pressure inside it,
Leading
to potential symptoms from the kidney itself, like hematuria or flank pain, due to that elevated pressure. But also, it causes blood to back up and reflex down the gonadal vein, which can cause pelvic congestion symptoms, pelvic pain, dyspareunia, vulvar varices or scrotal varices, varicocele in men.
So what are the key symptoms to look for?
The big ones are hematuria, microscopic or gross, and left flank pain. Pelvic symptoms like painful intercourse or menstruation, painful urination are also highly suggestive. And varices vulvar, scrotal, leg, gluteal, proteinuria, and general abdominal pain are sometimes linked too. There's a definite link with varicocele.
How do you diagnose it then, if the anatomy alone isn't enough?
It really relies on correlating symptoms with imaging findings. You have to rule out other causes first, like tumors. Duplex ultrasound is often the starting point.
What can ultrasound show?
It can show the narrowed vein, the dilated part beyond the compression, and measure flow velocities. A high velocity ratio, say 5.0, between the compressed segment and the dilated hilar segment is suggestive. It can also sometimes show collateral veins or reflux in the gonadal vein. but it's operator-dependent and can be limited by body habitus.
What about CT or MRI?
They're increasingly important. They can clearly show the anatomical compression, the beak sign where the vein narrows. They identify pelvic collaterals, gonadal vein dilation, and measure that aortomesenteric angle. Seeing those pelvic collaterals is pretty critical if they're absent. It makes NCS less likely as the cause of pelvic symptoms. CT seems particularly good for quantifying the degree of compression. MRI gives similar info without radiation.
And venography, measuring pressure.
Venography gives you the hemodynamics, the pressure gradient between the left renal vein and the IVC. A gradient of 3 mmHg Hg or more is often considered significant. It also visualizes the narrowing, the dilation, and reflux into collaterals. But the gradient isn't foolproof. It can overlap with normal, and in chronic cases with lots of collaterals, it might normalize. So it's part of the puzzle, not the whole answer.
Okay, management. What are the options if someone is symptomatic?
The goal is to relieve that left renal vein hypertension and reflux. For milder cases, especially in kids, conservative management observation, maybe encouraging weight gain might be enough as the angle can widen with growth.
But for persistent debilitating symptoms?
Then you consider intervention. Open surgery has several options. Left renal vein transposition is common moving, where the renal vein inserts into the IVC lower down, away from the SMA.
Sounds complex.
It is. Other options include patch venoplasty or maybe gonadal vein transposition, disconnecting the enlarged, refluxing gonadal vein and reimplanting it into the IVC directly. That avoids messing with the renal vein itself and seems quite effective for the pelvic symptoms. Some places prefer this now.
What about minimally invasive or endo options?
Robotic-assisted transposition is emerging. Endovascular stenting of the left renal vein has been done since the mid-90s. It can relieve the compression.
But is always a but.
But there's a significant risk of stent migration into the IVC, even into the heart or lungs. That's a major concern, especially with stents not specifically designed for this location. Long-term durability is also less certain compared to open surgery.
So the best approach is still kind of up in the air.
It's evolving, definitely. Open surgery, particularly transposition, renal or gonadal vein, has good documented outcomes but is obviously more invasive. Stenting is less invasive but has that migration risk and uncertain long-term data. Patient selection is key, matching the intervention to the specific anatomy and symptoms. Maybe future dedicated venous stents will improve the safety and efficacy of the endovascular approach.
Okay, wrapping this up then. We've covered a lot of ground in these miscellaneous venous conditions. What are the big picture takeaways for surgeons listening?
I think we've seen a definite shift. For SVC syndrome, endovascular techniques are often primary now, but surgery remains crucial for complex or failed cases. Understanding both is key. For portal hypertension, it's about mastering the spectrum, medical therapy, endoscopy, TPS, BRTO, and knowing when surgery fits in to manage those dangerous complications.
And Nutcracker.
Nutcracker is challenging. Diagnosis requires careful correlation of symptoms and imaging, not just anatomy. Treatment is really individualized, weighing the risks and benefits of open versus endovascular approaches, acknowledging the current limitations, especially with stenting.
So final thought maybe, as you encounter these varied venous issues, how can understanding these specific conditions, these insights from Rutherford's, really shape patient care?
Well, recognizing the nuances, the evolving etiology of SVC syndrome, the critical HVPG threshold in PHT, the debate surrounding NCS symptoms, it allows for much more tailored management. It moves beyond a one-size-fits-all approach. Hopefully this deep dive prompts you to think critically about these conditions when you see them and perhaps explore certain areas further for your own practice.
Excellent point. A deeper understanding definitely leads to better, more personalized patient care. Thanks for joining us on The Deep Dive.